All right, welcome back to the Owens Recovery Science Podcast. Want to say a big thank you first and foremost to all of you that listened to our Memorial Day 3-pack. We hope you had a great June, and we are back here hitting you with some cool new episodes coming up on our podcast. Today, you most likely have read this man's work. There's a lot of work out there of his to read, and you may have seen or listened to him on a podcast, seen him on a YouTube video. There's tons of free content out there from this gentleman that you can consume to learn all about BFR from one of the premier researchers in the entire world. Some have likened him to Wu-Tang Clan and their contributions to hip-hop. You most likely know him as Jeremy Loenneke from the University of Ole Miss. Dr. Loenneke received both bachelor's and master's degrees from Southeast Missouri State, then went on to the University of Oklahoma, much to Johnny's dismay, to receive his PhD, where he chiefly studied blood flow restriction exercise. Presently, Dr. Loenneke is at Ole Miss University. He is the director of the Kevzer-Ehrman Applied Physiology Laboratory, and his research group's primary focus is on skeletal muscle adaptations to exercise with and without the application of blood flow restriction. He is also a fellow of the American College of Sports Medicine, and he's a member of the American Physiological Society. And so without further delay, we are going to kick it to Jimmy McKay. Then he's going to kick it over to Johnny and myself, and we're going to let Dr. Loenneke roll. So hope you enjoy this episode. Feel free to shoot us any ideas that you have for stuff you'd like for us to talk about. Easiest way to do that is to email info@owensrecoveryscience.com. Thanks for listening.
This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
All right, fellas. You guys probably can't see this with my bad Zoom lighting, but I've got a savage Mayan tan going on right now from my trip. I just got back from Mexico. Our guest today, I'm going to introduce him in a minute. If you look out there on the internet, there's only one person that beats my tan right now. It's a picture of Jeremy Loenneke, bodybuilding with his spray on tan.
That's right.
Yeah, man. So I tried to get there, but it rained too much. So I can't compete with that tan. So anyways, our guest today is very excited. This is like, if anyone's followed blood flow restriction, which if you listen to this podcast, I'm pretty sure you do. This guy, Jeremy Loenneke. So he is prolific in the blood flow restriction space. I just looked to see how many BFR papers he's put out, and I had 142 out there. So I hate guys like this, just so damn prolific, put stuff out there all the time. But if anyone deserves credit for getting BFR out into the space for people to know, it's Jeremy Loenneke. Jeremy unfortunately did his PhD work at this community college called University of Oklahoma in Ben Ben's lab, and I think that's kind of where he started really churning out a lot of BFR stuff, and then he went down to Ole Miss. And just to kind of set the stage here for where Jeremy stands on this stuff, at the Center for the Intrepid, when we were looking at potentially doing BFR for combat casualty care, we reached out to just a few people. And the first person we reached out to, just because our guys at the Institute of Surgical Research were looking at all his work, said we need to call Jeremy Loenneke. So we called Jeremy in the early days to try to get a better understanding of what BFR was. Does it really do what it looks like it was doing, which seemed fantastic? And is it safe to put on the combat casualty? Then Jeremy became a consultant for the Center for the Intrepid and really helped us move things along. And since then, we presented ACSM together. We've been on several papers together. We've got a DoD grant, which if Jeremy wants to go into it, that we submitted a pre-proposal on, which I'm super excited, looking at hypertension. We'll be presenting at a conference here. It looks like, Jeremy, in September-ish timeframe as well. So anyways, without further ado, the one and only Jeremy Loenneke. What's up, man?
How's it going? Appreciate you having me on.
Good. Thanks for coming on. So, you do podcasts all the time. This is actually finally one of those podcasts where you don't have to explain what BFR is.
Right.
Which is nice. You don't have to do the 2-minute elevator pitch, but give us a little of your background and, I know you're bodybuilding and all that sort of stuff, but what got you into looking at BFR?
Yeah. So I was in sports most of my life. I wrestled from when I was 5 all the way through high school. Got into bodybuilding, which you mentioned. Pretty mediocre. Did some powerlifting, pretty mediocre. But I enjoyed kind of those activities. But when I was finishing up my undergrad, you had to do an internship. I was at Southeast Missouri State. So I was kind of looking at different places to do research. And I went to the University of Illinois and was doing some muscle work there with Dr. Huey. But I was kind of started reading some of the literature, and I was reading blood flow restriction. But to be honest, I was an undergrad and I read a paper where I think it turned out to be Dr. Abe's paper, but it's like you're recruiting or you're restricting blood flow and good things are happening. So I was like, well, that seems weird. I'm probably just not understanding, what I'm reading. So I went to Illinois, and then I was working out in the gym. Lane Norton and a couple of other people were also talking about blood flow restriction and kind of how they might be able to apply it. So I was like, oh, well, maybe I was reading it correctly. And I just started reading a lot on blood flow restriction, and it basically went from there. I went back to Southeast for my master's in nutrition and exercise science, did a lot of the practical blood flow restriction, at least initially, that work, and then went to the prestigious University of Oklahoma, where I worked with Dr. Mike Benben for 4 years. And then I took a position at the University of Mississippi, better known as Ole Miss. And I've been here for 7 years or so. So yeah, I've been lucky here to get a lot of good students, and we've been able to do and continue to do a lot of good work.
Well, I think that's your lab's becoming really elite in what you're churning out, not only in the BFR space, but in the muscle phys space. And I think the coolest thing is now we're seeing like the Jeremy Loenneke tree, like these young pups are going out and creating their own kind of labs off of what they learned under you. And so
they're very good. It's really cool to see for sure.
Yeah, they're spreading out all over the place. Explain. So Dr. Abe, he's the OG. And just brilliant guy. I think when I went to go visit you at Ole Miss, he unfortunately wasn't there during that time. But a little bit, you want to give a little his history. I don't think we give him enough props. And then is he still there with you at Ole Miss?
He was here. He just went back to Japan, probably for the foreseeable future.
Okay.
But yeah, Dr. Abe, I think the thing that a lot of people don't realize is when he came to the United States, he's retired. So he's retired, but he works more than probably anybody. And he's got a very, very young mind, great ideas. So, is a wizard with the ultrasound, great with students. So yeah, I think that his early work was in muscle growth, muscle physiology. He then started to, early on, do some of the blood flow restriction work, and did a lot of probably what I would call the landmark papers on that. But yeah, I got united with him because my mentor at the time was friends with him. So my mentor at Oklahoma, Mike Benben, went on sabbatical to Japan to learn how to do imaging with the ultrasound. So Dr. Abe and that kind of group, Fukunaga, who's a legend in muscle physiology, they did a lot of the early work on using and validating the ultrasound to actually use it to quantify muscle size. So they did a lot of all of that work. So Mike Benben went over there to learn that, and then he eventually came back over to Oklahoma, and that's where I met Abe. I'd been familiar with his work, obviously, but we slowly became pretty good friends. So it's this friendship / mentor. So yeah, we've stayed pretty close ever since. So even when he moved away, I would travel and we'd write papers on the weekends. He's just a he's a phenomenal mind.
Yeah.
And yeah, I think a lot of people don't know him and they probably should, for sure.
Yeah, well, and I'm a dummy Texan, so when we were first looking at it, some of our researchers at the Institute of Surgical Research, I was like, and this Dr. Abe guy looks pretty good, and they're like, dude, that's Abe, and they knew him from his ultrasound work, not his BFR work, but yeah, corrected my dumb Texas, don't know how to say Abe in Japanese. So yeah, that's so cool, man. And so you've also had like Laurentino, I know, was there for a while, and then the Brazilians kind of are doing a whole lot of BFR stuff as well. So it's kind of cool. This, when I talk to people and saying all this stuff's come out of Ole Miss, they're like, really, Ole Miss? But it's like, you got Abe, you got you guys, you got Laurentino going down there. Who knows who else is visiting? I was there for a day.
I remember that.
Yeah. Well, let's kind of. You've got 140 something papers. So I think what we should do is go over every one of those.
Start with number one. Yeah.
Let's start with number one.
Yeah.
I couldn't. Okay. I do know in 2011, you did the first meta-analysis, I think, that's been done on BFR.
Yeah.
So that's kind of how far it's gone back, but there were enough papers already in 2011 that you could do a meta-analysis on it. But how about what was your PhD thesis in?
Yeah. I was looking at, kind of the acute response to different loading and different pressures to kind of the acute swelling, the acute EMG response, the discomfort, the perceptual response. So we're doing a lot of different stuff like that. And then trying to set up kind of which protocol should we use when we actually run a training study, which is the first one we did when I got here. It was extremely small study, but looking at high pressures versus low pressures, and does that actually matter for muscle adaptation? And ultimately, it doesn't seem like it does, assuming you're going to failure. With muscle, we have some data that suggests that vascular adaptations might actually be pressure dependent, but I mean, that's very preliminary, finding. But that was kind of what I did for my dissertation, was just kind of looking at different combinations of load and pressure to try and see, when we do a training study, which one should we pick? Yeah, that's basically what it was.
I think that was one of my initial questions. I like typical clinician guy. Hey, Jeremy, what pressure should we use? What's the protocol we have for ACL? Like asking all this stuff early on. Man, just so much unknowns. We were having to just kind of guesstimate what we thought. Let me touch base, because we've got some kind of really interesting stuff. Not only with your grant, with some of the vascular groups at Walter Reed, we're potentially looking at BFR with dialysis patients to kind of dialysize or arterialize the AV fistula. And so what are your thoughts? You guys have done a lot of work on it with pressure for the vascular changes.
Yeah, I mean, I don't know anything about what you just described. And I think the way I always try to discuss it, especially when we start getting into the clinical world, is that I'm not a clinician. Right. But I do feel like I have a general pretty good idea of how it responds to normal people, healthy people. And I let clinicians take that with their clinical expertise and roll with it how they choose. Because and I'll get to the question here in a second, but when talking with you and going to some of these events I've been fortunate to go to where there's a lot of clinicians, it's pretty quick. You learn pretty quickly that, oh, wow, there's a lot of things that you need to consider when you're dealing with a clinical population. So I think approaching it like I have been approaching it has been useful. But I think with the vascular adaptations, when we look at, kind of increasing blood flow to a limb, those appear to be driven by local mechanisms. But it does appear, at least to us, that there could be some pressure dependency there. But then you have to kind of balance it with the perceptual response. Tolerance. So yeah, it's like, well, higher pressures might be a little bit better, but it's going to be a lot more discomforting. Is that something that we can balance out?
Right.
So I think the other thing that I'm interested in, and we've got some work that suggests that it doesn't do anything negative, is the venous side, which is largely neglected. Mm-hmm. I'm curious if when we apply repeated blood flow restriction, when we're pooling blood repeatedly over and over and over and over again, does that do some sort of valve damage? Or does it make the venous side not respond quite as normally as it normally would? And so far, it doesn't appear that it does anything negative to that, which
Right.
I think is good. But I'm still curious about that. And I think we need to do a lot more kind of larger studies. And I think that we've read enough of the literature. I know all of us have, that it does seem like it's overall safe. But I think one of the things that we need to know and this is something we can get from larger studies, is are there certain people that you're going to miss with smaller scale studies that maybe are contraindicated, that we can learn if we actually increase the sample size. So that's something that's also of interest to me.
Yeah, sucks because the increased sample size, it equals dollar bills, baby, and it's hard to get those, unfortunately. So yeah, and so that's interesting because what we're talking about with the bachelor guys at Walter Reed is if you're going to dialysis, they take a vein and they connect it to the artery in your arm, and it has to turn into an artery over time. And so it arterializes, but it takes 6 to 8 weeks. And if you can increase that time at all, that's huge for dialysis patients. Some people need dialysis like tomorrow. And so what those guys were asking, and they really feel like on what they understand, is that you can speed up this process. But they asked me what we had in the BFR literature that's looked at the venous side, and it was like pretty much nothing. It's all artery. But what they really feel is frequent bouts of very low pressure will maybe affect the venous side in a more positive direction. So we're hoping to kind of start looking at that as well.
Yeah, that's very interesting.
Yeah, I'm with you. It's all artery based.
Yeah.
Well, another kind of like, this is a bigger trial moving in another area, because you kind of like you built all the foundation for a lot of us with the muscle side, but you and Dominic and Nita just put out a paper, I think it was last year, on BFR and its potential for diabetes. And those guys, working with them, I talked with Dominic and years ago to set this trial up. What are your thoughts on the diabetic populations, and what do you think BFR can do, not only from the sarcopenic muscle, but also from affecting like insulin tolerance and things like that?
Yeah, I think I'll just be upfront. I just think we need data. Yeah. I think that's where we're at with a lot of it. I think that there's a lot of reasons to believe that it could be metabolically quite useful. I think a lot of the some of the data out of, I think, the Scandinavian groups have suggested there could be some potential there. Mm-hmm. And you can make a great case for why it might be beneficial for lots of populations, but I think we just have to get down and do the work, right. And get it approved and things like that. I think then we would know. But I think, I think it should be beneficial, but I think we just need to do some large scale studies. Yeah, I think we got to move past kind of this pilot work into some trials.
Yeah, I wonder if I could jump in and just kind of pick your brain, Jeremy. I mean, I would agree with you. I think there's a lot of space for data, just sheer data to kind of tell us about this. But if we're just talking BFR, are there responses to BFR that you think we really truly know? Like, we know this happens if you do BFR. And you could kind of run with that wherever that goes. But yeah,
I think that's it's actually kind of interesting that you brought that up.
It's a loaded question a little bit too, which I'm fine with. Yeah.
No, tell him it's a great question, because he gets this big head, and then when he puts it out, he's like, I had a great question.
Hey, Jamie Burr said it was a nice idea, Johnny. That's all I'm saying.
It is a polite Canadian.
It's a great question, because it's one of the things that we've kind of thought about too. And this is like 3 years ago when I was, I've also, outside of blood flow restriction, but it's related, is this idea of muscle growth and strength adaptation. So once we started seeing these repeatedly, I think one of the things that kind of like what you're getting at, Kyle, it's like, what do we actually know? Yeah. What not that we're linking together? What actually has some evidence? And I think what has evidence is we have a pretty good indication that when you do blood flow restriction, you will see an increase in muscle size. You will see an increase in muscle strength, assuming that the load is probably around 20 or 30% of your 1RM. I feel pretty confident in saying it will not be as high as high load exercise, assuming you don't repeatedly practice, but it will increase. I think there is a real increase in strength, and I think that the muscle size is very similar to that of high load exercise. That I feel completely confident in. I think it's pretty repeatable finding that with higher pressure, there's greater discomfort. With higher pressure, the acute blood pressure response might be a little bit higher, but probably not higher than high load exercise.
Right.
Probably pretty similar. And importantly, it comes back down to baseline, at least in normal, healthy individuals. So it's not that you increase blood pressure and it's elevated for the next few hours. At least the data that we have, it usually comes back within 10 or so minutes in normal people. So that I feel quite confident in saying. The vascular side being pressure dependent, I'm not as confident. I think we have very limited data, but might be something that would require a higher pressure. What's interesting about that vascular data is we had people doing a tremendous amount of repetitions, because the whole adage is as long as you do enough repetitions, you don't need blood flow restriction. And I think that's true for muscle growth. But with the vascular adaptation, that's not what we saw. We saw that it was pressure dependent. So that I think would be worth investigating a little bit more.
That's awesome.
I don't know.
You didn't say systemic effects, Johnny. There was nothing systemic in there.
Did you bring up systemic? You're gonna get
No,
angry people.
it's just where everything goes sometimes, I feel like. And I've seen Jeremy's opinion on systemic effects of exercise.
Yeah.
I think it depends on what it is. Muscle, at least the response to exercise with muscle growth seems to be pretty local. Seems like that might also be the case with vascular adaptation. I think if you're looking at changes in like pain tolerance, changes in pain pressure threshold, that does appear to be quite systemic, which I was surprised by, to be honest. I'm always pretty skeptical about some of that, but we had a control group, and we did find global responses to pain in both blood flow restriction and non-blood flow restricted exercise. Isometric hand grip, that's under review right now, but if I didn't have that control group, I would have not believed it. And if I don't know, I was quite surprised, but I'm convinced that there are some things that are systemic, but the muscle stuff, I don't think so. And that goes back to a lot of the Matarame paper, one of the Cook papers, where they see what they perceive to be global changes and adaptation. I'm not convinced that that's a repeatable finding, but I could be wrong, but I don't think I am about that.
I think we're moving on from that, although speaking at an orthopedic surgeon conference, and that's the first thing they go to, what about the systemic effect and growth hormone? And so, but I agree. I think muscle, vascular, if maybe we really start looking at this with bone, that stuff that we're looking at needs to be local. But, if your paper, when it comes out, it's going to kind of back up what Luke and Stephen found as well with this kind of systemic pain analgesic effect.
Yeah, we're doing a follow-up right now that we just got approved a couple of days ago that will hopefully look at this as well, with a little bit more of a dynamic exercise protocol. We had moved to isometric during the pandemic because we could control that very well. We don't have people moving around. So the isometric hand grip itself is a pretty cool modality, but we didn't find blood flow restriction was able to augment that. But the isometric hand grip by itself is pretty intense at 30%, which I was surprised by.
Much harder than you think.
Yeah.
Well, I think on the clinic side, we've seen the pain reduction too, clinically a little bit. I mean, one of the really kind of remarkable pain reductions that I got out of a single patient was post-op ACL, and we combined neuromuscular stem with BFR, and this dude had been in pain for 3 weeks, and he literally just walked out in significantly less pain. And when he came back the next visit, significantly less pain. So it was very interesting to see that. I'd be curious to see if some people do some pain work with neuromuscular stem, because I'm kind of curious there. That could have a lot of value for like a total knee, an ACL reconstruction, that kind of thing. So
Yeah, there is a couple studies on the E-stem. I don't know specifically about I don't think they included a pain assessment.
Yeah.
But it did appear to be somewhat useful. But I agree, that's a cool area for sure.
Yeah, we're seeing a lot clinically. Like our first RCT we did in the DoD, you included in your pain review that you put out there. We were already seeing this analgesic benefit in the service members, so we made sure because we couldn't find really anything in the BFR literature that had addressed pain at all. Because there wasn't just much in the clinical populations, and the ones that did just looked at string hypertrophy. So we added the COOS to it, and they had significantly improved pain scale after 4 weeks of doing it. So it was cool to see. Well, getting back off of this, global versus systemic type of thing, I think we can kind of close the door on that. But, we did a paper, Lessons from the Lab, several years ago, and you've done a lot of work at looking at what do you think on the proximal side? Abe did the cool paper where we saw some nice change in the glute. So what do you think of proximal, the best way to go after that?
Yeah, I think that's another one that I think we just need more. And we have seen it a couple times, but I feel better if we did it again with a control group. But it does appear that it's possible that if you apply them to the proximal portion, so the uppermost portion of your arm, and you're doing like a bench press exercise, that the chest may pick up some of the load when the triceps fatigue. Right. I think depending on the population that you're doing it with, I think one of the things that you might be able to do is just superset it. So do something where you're going to fatigue the triceps and under blood flow restriction, and then go to the chest press, and then it might be able to ensure that it's doing a little bit more. Messing around with it myself in the gym, I do feel like there is something to it, because it's like I've been to where it's almost where it's cramping up. I mean, it's not under restriction at all. But I'd feel more comfortable if we had some larger studies. But I think when you say it's possible, I think the next question that people have is, well, how's it working? It goes to is it a global response? I don't think so. I think it could be a recruitment activation response, but again, that's just another hypothesis.
Yeah, I think we feel it's a recruitment thing, and our best guidance right now is, it probably needs more volume, maybe more load, because this is a recruitment thing. It's not going to fatigue like the quad will if you're going after the glute with these like Jane Fonda exercises in rehab.
Right. Yeah.
Brad Lambert's shoulder paper just came out last week. And they did find some pretty good changes in the shoulder. And they had a control group that didn't do as well, but it was pretty high volume, four shoulder exercises, which go do 4 BFR shoulder exercises and you're freaking smoked, man.
Yeah, for sure.
Yeah. And we do so many labs, teaching these courses to clinicians that we see in the lab, having people doing squats with BFR on one leg, or, some sort of shoulder scaption exercise with the cup on one arm. And, majority of the time they're like, damn, this is really harder, and I'm feeling much more fatigue in my proximal muscles when you're doing it unilateral.
Right.
So there's probably something about with you. It's the most common question we get, and obviously it's the one where we're like, we just really don't know right now.
Yeah. Otherwise, they feel like it might just be limited to the extremity.
Right. Yeah. So much of rehab's the shoulder and the hip.
Yeah.
So if we do start seeing good changes there, that's going to be huge for us.
Yeah.
You put out an interesting paper, and I haven't been able to read it fully yet, about BFR and the potential for changes in cognition. I want to kind of go down that road as well. So, I got people texting me like, cool, it makes you smarter now. What does it not do, type of thing?
Yeah. I think I also want to be clear that I'm not an expert on cognition. We were able to work with Dr. Emily Frith, who's at Penn State right now. And she's really good with that kind of thing. But my student, the lead author, Yuji Yamada, he's read a lot of that work. I think the idea started at ACSM a couple years ago, actually probably 3 years ago at this point. George Brooks was given the Wolf Lecture, and he had a postdoc or a PhD student, Hashimoto, who presented some stuff on lactate and executive function, which is kind of one of the domains of cognition. And it's more specifically interference control.
So, which is very important element of cognition, but they found that there could be something there with lactate being used as a fuel for the brain and improving one aspect of cognition. So we reached out and we partnered with Vasper on a study, which was started and then stopped immediately due to COVID. We have yet to be able to start that up. So it's a little bit different type of blood flow restriction, but I think it. But that is something that we're interested just in general. But it appears that, because my thinking was, sorry, I'm rambling, but my thinking was with the lactate, lactate is something we see is augmented quite often with blood flow restriction. So I wonder if we were able to produce a little bit more, could we augment interference control? So that was kind of how the paper got generated. And then he was looking at multiple domains, but the one that has data behind it, only about 2 studies, and only one of them was I think a really strong study, but it was published in MSSE, did suggest that when you walk with blood flow restriction, you did see a little bit of a greater change in lactate, and then you saw a little bit of a greater change in executive function. But those are just parallel changes. It's not necessarily meaning that that's what did it. But I do think that that's an area that has a lot of potential. So the thing I liked about that paper is that we covered a lot of different domains and covered how to investigate each one of them, and then kind of laid it out. If this is something you are interested in, here's how you might be able to address it. So I feel like it's a hypothesis paper, but it lays out some ways that we might be able to get at some of these questions. So I thought he did a really nice job at that. And I feel comfortable only because we had somebody who she actually has a PhD in kind of health and exercise science, as well as a PhD in psychology. And now she's doing a postdoc at Penn State in kind of a neuroscience lab. So I only felt comfortable diving into that because we were able to work with her on that manuscript. So, but I do feel like that's an area that hasn't received a lot of attention. So I've become a little bit interested in that.
No, it's super cool. And, the whole lactate shuttle theory and everything, it makes perfect sense. The beautiful thing with BFR is you can really trap and hold lactate for a long time. I mean, it's kind of way different than you could ever get with just traditional exercise. So, it could be this, you just get it in there, keep the cuffs on, just keep it trapped. And then release it. With Vasper, you couldn't get enough pressure up to get the lactate response. Such low pressure.
It is difficult to control the pressure because it's fluid pressure. So it'll be interesting to see what we see, but I think that and there's a lot of combinations going on with Vasper. They have the cooling, so which could have its own benefits. But I think that review was more focused on traditional blood flow restriction, so just applying the restriction. But I guess to get to Kyle's earlier point, that you could argue that that's a systemic effect if it's real. You have the lactate produced from the muscle going to the brain.
All I heard was you said systemic effects are real, Jeremy. That's all.
Hey, we're going to tweet this podcast out. Jeremy believes in systemic
Jeremy effects. Endorses systemic effects.
It just depends. Depends on what it is.
Well, we should talk offline. Carrie Hoppus, who's at the Army Baylor Schoolhouse here at the base, she does a lot of neurologic and cognitive function stuff. She's always been kind of hit me up on where to go with BFR. I need to send her this paper. And we got all these students, we discussed this because there was talk at one time, you kind of feel like you're more in the zone. Sometimes you get done with BFR and it's almost like a mind F, you're like, what the hell just happened to me? But maybe in the zone. And we discussed with some of the special forces guys, maybe get in the shoot house and just seeing if it made your shooting skills better after a bout, and did that do something to you?
Yeah, that'd be interesting.
Yeah, we got that here.
I would be willing to be part of like that pilot data. That sounds like fun to me.
We'll go up to Fort Bragg behind the gate there, and
I'm in.
Shoot the real guns. You did early on, like a lot of the discussion, and I'm not sure if you did any of the studies, but about this whole passive BFR or self-swelling approach. And so, it's always a little confusing to people when you're discussing it, You want to go in, your thoughts on what's happening to BFR with a lack of exercise and mechanisms maybe?
Yeah, I'm very interested in that. We've done a lot, not a lot. We've done some acute work on that, but none of the, long-term studies where you're just applying a cuff. I mean, I think that has some real utility maybe when you can't do any exercise. And that's work that is best done in kind of a hospital setting, in my opinion.
Yeah.
But I'm interested in the swelling effect. I mean, me and Abe wrote about that a long time ago. I think that may have been our first paper together on the acute swelling effect. And I feel like we have some indirect evidence that when you do cycles of inflation and deflation in the absence of contraction, it does appear that the muscle itself swells more so than just venous pooling. So some of what you're getting from the image is just a collection of blood, but we see it maintained, at least to some degree, when we deflate the cuff. So we think that there's some swelling that's actually happened. So you can, again, make a lot of hypothesis-driven kind of ideas for how that might be anabolic or how that might be anti-catabolic. I don't know how important the swelling effect is when you combine it with exercise. I think the activation, all that other stuff, I think may supersede it. But I am interested in if there really is something beneficial going on when we apply a cuff in the absence of exercise. I just wonder if some of that's not driven by swelling, because the mechanisms behind growth could potentially be quite different than the mechanisms behind maintenance. Right. And I think you could make that argument that they are. So I think the acute swelling response, that kind of that pump, I think there could be something to that. My opinion on it with respect to exercise has lessened substantially over the years. And to be honest, it's quite difficult to even study that in exercise because swelling is almost always going to occur.
Yep.
But I guess in that case, if swelling does occur, then and growth is greater in one, then maybe we've already answered that question. But so maybe it's important for maintaining, but not so important for changes in growth. But
in your gut, do you feel like it's more of a catabolically down regulation versus maybe driving a bit of mTOR? There's that pilot, I forgot who the authors are, that they showed MERF1 was decreased when they did it passively versus not doing it.
Yeah, I think it could be. I really struggle with it, to be honest, because you could argue, well, MERF1's not, that's a marker, but it's not actually quantifying breakdown. And then you have the protein metabolism guys who would say, well, do we even want to suppress breakdown? Is that a good thing? And it's probably always a balance anyway. So I don't know. And then I wonder how much of it's confounded by we're looking at the growth literature and trying to make that fit to a maintenance literature, because I think that's starting to come out that those might be completely different things. But
well, in the clinical side, we're not in the growth,
Yeah.
We're in like shit's going to hell in a handbasket right now. This person is just breakdown. They're losing it quickly. So if you can slow that, this passive is the best clinical application I think you could have. I
think it's worth trying. And I think one of the papers that we wrote early on was this idea of progression. So if you can resist this exercise, then do that. If you can't, use blood flow restriction. If you can't do that, can you walk? Maybe walking slowly won't do anything, but walking slowly with blood flow restriction might be able to help you get back to your baseline. Right. Can't walk? Well, try this until you can do that. And that was kind of our idea, is to progress back to your normal life. Because to me, maybe it's a very reductionist way to think, but I want to know what happens when we just apply blood flow restriction, when we don't add something that's so powerful already, which is exercise. Mm-hmm. And I really have a tough time discussing it because there is published data that suggests that maybe there is something to that, but not a lot of published data. And in my mind, I start battling. It's like, is there a reason why there's not a lot of data? But
You're back to the old Jeremy undergrad reading the BFR literature again.
Yeah.
Like,
So
it's one
of those things where it's like, maybe it's worth trying.
Yeah.
And I think you have some foundation for why you think that would be useful to try, but not a lot of data. But I think there's good reasons why it might work.
And I think there's this new bucket that we're really looking at clinically is, just hypoxia. It was BFR and exercise, and now does this hypoxic event and the swelling event drive something? And it's pretty cool to see it go that way. We're starting up, just went through IRB, a hip fracture trial, inpatient. So we'll be applying it with E-stim. So just very minimal contraction in elderly hip fracture patients in the hospital for 2 weeks, basically, and tracking them as they go to like a step down facility. They'll still be doing it. So we'll see, because those folks, that's lots of times life or death. Hip fractures will take out Grandma Smith. So it'll be interesting to see.
No, that's awesome. I mean, especially if we can get it to where it's better, exceeds the standard of care.
Yeah. What about your thoughts on doing aerobic? So Abe put out, probably the classic aerobic paper, 15 minutes on the bike. Just everything was really great, that came out of that study. So much so, right off the bat, that's how we started applying it at the Center for the Intrepid when we did aerobic. Just jump on the bike and put the cuff on or cuffs on. It sucks. It's so hard. We've actually, I'm kind of a high pressure guy. We were doing everything at 80%, and I've seen some people crash and burn, like catch up off the bike. So we've been really tapering it down to 60%. Starting out, we actually got a group here in San Antonio that did a study for us. It looks like 60% kind of did everything that 80% would do for us on a walking or bike protocol. How do you like to skin the cat on aerobic? Steady state, pressure, maybe thoughts, or intervals?
Yeah, that's one where I think that and I haven't done a lot of work on the aerobic side, mostly because I think that it does have some real clinical probably utility. But I think, and there's never been a head-to-head comparison in the same study, but I think the biggest bang for your buck will be resistance training with blood flow restriction. But to your point, if you can't do that, my guess would be is walking probably higher pressure is probably going to be pretty important if they can stand it. I think when they cycle in your protocols, are the legs out in front of them? It's like a recumbent bike?
No, regular. Usually just a regular upright.
Because I feel like when your legs are out in front of you, I feel like it's way more intense.
I would agree with that.
Than a standard bike.
Yeah.
The walking protocols that we've done in the past, I honestly did not, for a normal healthy person, did not feel like it was
they're not bad.
That intense.
It's the cycling.
Yeah, my guess would be, and we've done some cycling in normal people, but back when I was at Oklahoma, but the protocol was based on heart rate. So there was a lot of issues with how we applied it, which we now know that you shouldn't do that. But I honestly still don't know how effective it would have been in that population because many of them are so active that they're coming to work out at an intensity that's much lighter than they did to get here.
Right.
Whereas I think with resistance exercise, even when you're at a low load, that's pretty tough exercise. So I think with aerobic, keeping in mind I haven't done a lot of work in that. I think the higher the pressure is probably better. I like steady state.
Yeah.
Just keep them walking. I think the Abe's early work with the straddling the treadmill, I don't know for sure. I never asked him, but my guess would be is that that's kind of getting at kind of the sets, and plus it allows it to pool a little bit of blood because you knocked out the muscle pump when you're just straddling. But yeah, I think if you're a normal, healthy person and you're doing aerobic exercise with blood flow restriction, thinking that you're going to see large changes, I'm not sure that that's going to be the case. But I think if you cannot do resistance exercise, or you're limited, or you're in rehabilitation, then it might actually have quite a bit of benefit.
Yeah. And it's so, I don't know if you've ever gone through rehab, but, typically it's like go warm up on the bike for 10 or 15 minutes. It's, that's so you can go check your Tinder account as a therapist, or go mess around in the back. And so now, at our place, there wasn't a warm up on the bike. If you went there was cuffs all around the bike, and it was warm up on the bike, but make sure you get one of the techs to get a cuff on you. And so it's beautiful because most people are able to spin, but that's one of the few things they can do, you know, if you're like 2 weeks out post-op ACL type thing.
Right.
So it's a super easy kind of, I love that protocol. I don't think it's done enough clinically.
Yeah.
You guys discussed before we got on, and I was in Mexico. I probably could have read the paper because I spent my last 3 days on the pot. You had a paper come out, Kyle, you said last week, and I don't even know what it is. So you want to go into what that paper was?
Yeah. As you know, we've gotten kind of into the kind of blood pressure response. And I think that, you know, there are some people who have published some papers who are kind of raising kind of the question of, you know, what does blood flow restriction do to the cardiovascular system? And most of them are focused on the acute change. But again, I think a lot of that's a little bit overstated in my opinion, because generally they're looking at the acute response to blood pressure. And they're saying, you know, when we apply blood flow restriction with the, you know, we get a blood pressure response. When we do the same exercise without it, the blood pressure response is lower. But it's like, of course, I mean, you're restricting blood flow. But I think the important point is that what's the magnitude of the change? And it's usually comparable to, sometimes it's greater, but usually comparable to high load exercise. And it's very acute. So it goes up, but it comes back down. Now, I don't want to discredit their paper because I do feel like one of the things that they said is that there could be some populations where we really need to think about this, where their response with the sympathetic system could be much greater than a normal person. So I think those papers are very important, but I think sometimes in the context is lost when people are translating that out. So in our minds, I was like, well, I'm interested in so if we have a blood pressure response, kind of like with high load exercise, okay, it's acutely elevated, but what does it do to the resting level? So I had one of my students, Vicky Wong, I had to go through all the literature and we were just do a meta-analysis, you know, where she was in a class already, kind of learning about meta-analysis. So I kind of expected there to be quite a bit of work looking at that. And she comes back and she's like, I found 4 studies. And I'm like, you need to go back and look again. Yeah. And she's great. And she's like, okay. So she went back and looked again. I was like, something's not right. And I think what the problem is what our criteria said, we needed you to do blood flow restricted exercise compared to the same exercise without blood flow restriction. And it had to be between subject. So that eliminated a tremendous amount of studies. So lots of people have looked at blood pressure, but very few, only 4 to our knowledge, have looked at the change in blood pressure where the only thing that differs is the application of blood flow restriction. So we were looking at systolic, diastolic, and heart rate. And I think the biggest point of the paper is how surprised I was at how little work has been done. Yeah. And, you know, a lot of it was to help us prepare for the grant that, you know, you helped us with to try and look at some of this stuff with larger sample sizes. But all of the studies that were included, none of them were seeking to study the effects of blood pressure. They were all secondary. That was their just something they did. It was not the focus. And I think that's pretty important. So we didn't find any difference in diastolic. We didn't find any difference in heart rate. We did find a little bit of an elevation that exceeded the control with systolic. Systolic, yeah. But the confidence interval is very wide. So we didn't estimate with any precision. And there's just not a lot of studies. So I think the biggest surprise is how little studies have actually designed to answer that question. Yep. Because many studies are looking at high load versus low load BFR or within subject, which is our lab has done a lot of. So it's like, yeah, you can look at within limb changes in blood flow and vascular changes, but the blood pressure data is really irrelevant because both limbs are impacting it.
Right.
So yeah, I think what it tells us more than anything is that we need larger studies that are specifically designed to answer that question. So we're in the process of doing that. We'll have an answer with that, hopefully with the DoD grant, but if not, we're going to be looking at that next year. My student Rob Spitz is proposing that in the fall to look at that with large sample size. So I think that would be hopefully quite useful, because if it does impact resting blood pressure, what is the magnitude of that? And if it doesn't, then that would also be good to know. But I'm not convinced that it does. I don't think that this would sway me, but what it does tell me is that we don't really know.
Yeah.
We need some studies that primarily looked at that, because most of the studies were focused on looking at muscle size and strength. They just happened to measure blood pressure. So,
yeah, we did a systematic review analysis looking at the studies that looked at BFR in individuals with hypertension. I think we found 5 papers. And again, it wasn't even that the BP was what they were looking at. Like you said, it was all about muscle strength and size. And same thing, just a rise in systolic, but didn't even see a significant rise. Everything else kind of stayed the same.
Yeah, and I think that, I mean, that's no shot at those papers. I mean, that you focus on what you're trying to focus on, but
Right.
I think what it tells us is that, okay, maybe that's an area where we can do a lot of good work, and where it could be nice and novel.
Well, and that's the thing, the work's not out there, but then some of these papers, like you talk about, that throw out something like a call for concern in their title. And it's just kind of like, well, I get your point, but we don't even have that for this paper to be this kind of inflammatory and freak people out a little bit.
I think so. Yeah, and to your point, because I did suggest that, well, there might be certain populations where this could be a big concern, but again, we don't have that data either.
No, I know.
But still, I still agree with the point being made by the authors. But yeah, I think that when I first saw it, I was like, oh, wow, did something come out? But I think that when you're mixing and matching, especially the older literature, because, they weren't applying relative pressures. And I think that we think that might be important. Maybe it's not, but we think that we know the acute response does appear to be pressure dependent. So it seems like it probably would matter. But those older studies, they weren't able to do that. So
yeah, it's so hard to tell when we look back at those. And Larry Cahalan, who's down at University of Miami, does a lot of cardiovascular work. We work with him quite a bit. So far in his pilot, looking at heart failure patients, the worst ejection fraction, so the worst patients, as far as heart failure is concerned, are responding the best from what he's looking at with BFR. So moderate heart failure is doing okay, but the worst ones are, the worst ones are really responding the best, which is very interesting. And I think that's what's so cool where we are, and like, your DoD grant, if we get it, that's where BFR, man, you'll just see this crazy proliferation. Like we got a couple 100,000 ACLs a year in the US. We have millions of hypertensive individuals. And if all it takes is some hand grip and a tourniquet or something easy like that, to change BP, it's huge. Or if Dominic and Nina's, diabetes trial shows that they can control insulin tolerance, holy heck,
Yeah, for sure.
Yeah, that's crazy. Well, speaking of, we talked to Jamie Burr a couple of weeks ago about this. Speaking of people putting out a statement to something, the muscle damage piece. So we did that Frontiers in Physiology paper, and then we had some of our colleagues out in Europe say that, BFR looks like it should be a cause for concern on muscle damage. What are your thoughts? We did a response to that.
I
think go ahead.
I think that I thought we addressed that in the original paper.
I think we did very well.
I thought we addressed that. There might be certain people where they might respond negatively, and it might be worth easing into that. I think we also talked about the repeated bout effect. And for me, with the safety, I think the question is not, is there a risk? Of course there's a risk, but the question is, does it increase when you apply blood flow restriction? Is the risk increased over the same exercise without blood flow restriction? To me, that's the question. When we look at the muscle damage, overall, it doesn't appear that there is. So I think what their letter wanted to do was highlight certain cases where maybe we should be more focused. And maybe there are certain people who maybe they are more damaged, but I thought we highlighted that in the first one, but maybe they wanted us to highlight that just a little bit more, which we did in the response. But yeah, I think that the part that I struggle with personally too is that we do see soreness, a hell of a lot of it, but we very rarely see prolonged decrements in torque. And even those groups, when they look at the fiber, I don't know that they've ever seen structural damage to the fiber. They see some stress, which I could believe, but all the Z lines seem like, if I remember correctly, intact.
Yeah.
So
taking biopsy stuff, looking right at the muscle fiber, it looked great. Right.
Yeah. So, but again, I guess to their point, there may be certain people who you want to, be more cognizant of, but I think that was addressed in the initial one.
Yeah, and you can't base anything off just creatine kinase. And if that's what you're hanging your hat on, I could get CK levels on service members after doing heavy rucks all day, and they'd be through the roof. But I'm not sending them to the ER. There's a lot more. I think it was Jamie Burr who brought that up too. I think that was actually new to me. I didn't realize that there was maybe different thresholds for, have you just done acute exercise, or have you done. So I remember when we did a case study several years ago on a bodybuilder, and we didn't ask him to alter his training ever. We just took the blood whenever it was scheduled to take it. And his creatine kinase always came back flagged, because it was always after like some heavy leg day, always. And they're like, you need to look at this creatine kinase. So I was like, oh, I guess it's not that big of a deal. Yeah. Yeah. There's a lot more cluster of findings that we have to see clinically to be that concerned.
Yeah.
Yeah. I'm with you. It's interesting. Dude, everything you've done from the translational space has been huge for us on the clinical side. And I love now that you're moving into the vascular and hypertension. I mean, this is going to be huge for us having you involved in that clinical population. And I'm hoping we get this grant, we can move that way. So anything else you want to tease, or you got coming out, or you're interested in, or?
Yeah, I think that, we've always, and, you talked about some of the early work. The first ever work I did was trying to develop kind of a practical way to apply this to, not to clinicians, but to normal people in the gym who don't want to buy some sort of system. So I've always had some interest in that. Zach Bell's my student who's been focused on that most recently. But I think we're always doing some sort of work with that and trying to see, can we teach somebody to feel the pressure? And then they can apply that with the cuffs themselves. I think we have a lot of work to do on that. I think that when we do it, the range is so wide. But I mean, none of it's under arterial occlusion, which is good, but I think we have a lot more work to do using that method. I think Abe's work, where we pulled at a specific length and looked at the reduction in blood flow, that actually probably is the clearest way to do the practical work. But again, I think I would only recommend that in people who aren't in a clinical setting. I think in a clinical setting, you need to know for sure what the pressure is that's being applied. But yeah, I'm never going to completely abandon that. I don't think. I'm always interested in that. That's what my thesis work was, using knee wraps to try and figure this out. That was my first paper, was kind of proposing that idea back in, I think, 2008. But
well, that's big for us too, because we're doing it in the clinic. So we're endorsing it, and hopefully you're doing it right. One of the problems with, if you're trying a practical or some of these pump uppy things, there was a paper with B Strong where lactate didn't increase, rate of perceived exertion didn't increase, and compared to low load, and then the Hokinsons, everything was much, much higher. So it's like, if you're using something like that in the clinic, you're probably cheating the patient as well. That's not cool. But we're endorsing it, and the patients get done, and they're like, how do I do this now if I want to keep doing it at the gym? And last time, oh geez, I don't know. Here's Jeremy's papers on wraps, but if we could dial that in and say, okay, yes, you can, because nowadays, dude, we're getting cut on patient visits like crazy. So if we can get them in maybe early, use it to really slow down, the passive, low, and then get them off and maybe do it some on their own. I think that's huge.
I've kept that in mind, because I think I heard that maybe from you or maybe some of the other clinicians. So, when we're trying to train people to sense the pressure, we do it once in one visit. with the idea that, I mean, this actually does mimic probably the rule. We don't have multiple visits to try to get them to sense the pressure.
Yeah.
So I think we might be getting closer on that, but I like the new stuff that we're doing, but I always like the practical side as well, and how and to be fair, in a normal person, the pressure range that we can get, it probably doesn't matter. You know, you're not going to be under arterial occlusion using the method that we've used so far, at least in the first couple of days. So we feel pretty comfortable that you're going to be in this wide range. Right. But it probably would work. Yeah. Probably would be better than just doing it without it. You'd be able to do less work, see greater adaptation. But I would not feel comfortable with that in a clinical population where we need to know for certain.
Yeah. And I think you've repeatedly said that, Jeremy. I mean, I've heard you on a number of different podcasts. And I think anytime the clinic gets brought up, you make that point, you know, like clinical setting, you really need to know. But yet I feel like on our end, as we try to teach clinicians this stuff, we still end up getting people saying, oh, well, I heard I can just do 7 out of 10. I'm like, but the guy that wrote that paper has said you shouldn't.
Yeah. I don't understand. The 7 out of 10, I think we have to abandon for sure. Completely. That is, I think when that was first proposed, you know, one of the things that wasn't considered is that, many of them may have been below arterial occlusion, but the range of pressure is so wide and what we found is that last couple of years, Zach Bell again, is that you may be at 40% your first day, but the next day you might be at 110%. So it's 7 out of 10 changes. And I think that makes it untenable in practice.
Yeah, I agree. Well, cool, man.
Well, I think you see that with other papers too on the perceptual side. You know, people just get more tolerant to the pressure, which seems like kind of logically that would be the result of a 7 out of 10 is what you perceive as 7 out of 10 changes over time. So.
Well, I think, Jeremy, didn't you put a paper out on Perceptual, you know, that over a few weeks, most people will tolerate it?
I do think it's a little different because the discomfort to exercise versus the perception at rest might be different. But I think the cool thing about that paper where we looked at I collaborated with somebody a long time ago where we showed that. But I think the cool thing about Kevin Maddox's paper is that we showed it to progressive exercise. So even though we kept progressing and they were doing more and more and more, the discomfort did reduce. It was still higher than exercise without it, but it did reduce over time.
Yeah.
Which is, I think, quite useful.
Yeah. It was like that old, I think it was a practical paper as well, but you know, the rugby players, they measured their cortisol levels, you know, when they first started BFR and perception, and they both kind of trended down over time. Also, maybe it just wasn't stressful. Attenuated to it somehow. So, well, man, I don't want to keep you too long. We've passed our hour mark here. This was badass. Could go on for hours with your 142 papers. But again, thanks for everything you've done for blood flow restriction, the clinical side. Like I said earlier, we've got all sorts of rewards from your work out there. And what do you call your lab? The muscle lab, or?
Well, the hashtag I always use is Ole Miss Muscle. Our actual lab is the Kesler Ehrman Applied Physiology Laboratory. Okay. So it's named after a student who had passed away some time ago. Not one of my students, but we still try to honor her. But all the hashtags are Ole Miss Muscle.
All right, that sounds cool.
Yeah.
Saw on Instagram, I think that you just lost your coffee maker recently. So.
Yeah, we did.
Our condolences on losing the coffee maker.
I appreciate that. I
saw that. It looked like it was from like 1979. That thing, was pretty full of bacteria.
All of my students, they know how I am. I will use it until it goes into the ground. And many of my students have been, you know, they'd say, we can bring in a coffee maker. I'm like, the coffee maker we have is fine. But we started to run into issues where it would turn off. So we taped it on, and then it would, you know, we ran into what I would consider maybe some fire hazard. So I was like, okay, actually, I didn't make the decision. I was still fine with it. Vic Wong, she was like, she just brought in a coffee maker one day. So I don't like change. I like things how they are. But I did see that it was time to move on. But yeah.
How'd the lab bird down? That damn coffee maker.
Well, my students will laugh at this too, because I have a complex when it comes to that. I'll text them repeatedly, or there's nights where I go back to the lab just to make sure that it's off. I have these weird fears where I'm like, we're never going to, like, something's going to happen with the coffee maker. The lab's going to burn down, and I'm never going to know the answer to this question. We're going to lose all of our data. So
there goes all the blood.
Yeah. We have protocols though. It's like we have tornado warnings. It's like, where's the ultrasound? Just protect the ultrasound at all costs. But yeah,
That's too funny.
We've moved on with the new coffee maker. It's not like the old one, but I'm sure I'll learn to love it too.
Yeah, well, it's kind of like getting a new dog or something.
Yeah.
It'll be endearing to you. I'm sorry about the coffee maker. I didn't know it was that close to your heart. That's your change cycle.
No, I appreciate you guys having me on. I appreciate the kind words. I think the being, surrounded by good people for long periods of time has been tremendous. I think Dr. Mike Benben, and then connecting me with Dr. Abe, and then, it's sometimes you go through cycles, but I've been lucky to where every kind of student cycle I've had has been really good. So all my students who just do such good work, and then many of them who have graduated, they've also started their own labs, which is cool to see. So I've been extremely fortunate, extremely lucky, and I hope that continues for me. But I'm very lucky, but I'm happy that we've been able to do and continue to do good work.
Yeah, you're kicking ass, man. Empire builder down there.
Trying.
All right, so this year, hopefully I can tweet out all sorts of UT kicked OU's ass finally in the Red River rivalry. It's been forever, man. So
I can tell that I feel like when you went down to Mexico, did you get a little sick? You're not thinking well? There's no chance.
Yeah, maybe I got brain damage. We still have Vince Young as quarterback, right?
Yeah. The university, the prestigious University of Oklahoma, I think there's a good chance, we got the rattlesnake at quarterback. I think there's a good chance that we win everything.
Oh no.
We'll probably
our Zoom. We got the short-term Zoom account. It's about.
No. We're gonna lose to Iowa State or Kansas State, but we'll make a run at the end.
Yeah, you whoop our ass and Kansas will beat you. All right. Thanks, Jeremy. I guess we'll be seeing each other September and talk soon. Hopefully, we're working on a grant here in the next month.
Sounds good. Thank you.
All right, later, man.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.